This conference will now be recorded.
Good afternoon, all of you. Am I audible?
Good afternoon, ma'am.
Okay. So today's topic is ocular manifestations in AIDS. You know what is AIDS? What is HIV? Right? So acquired immunodeficiency syndrome, which is caused by human immunodeficiency virus, which is a RNA retrovirus, right? So modes of spread: sexual intercourse with infected person, use of infected hypodermic needles, transfusion of infected blood through blood transfusions, and transplacental, right, from mother to fetus. Okay, that's the reason always the needles should be disposed on a single use. So what is the pathogenesis? HIV infected T cells, T helper cells, macrophages and B cells. They interfere with the mechanism of immune bodies and also the production of immune bodies. So it renders individuals prone to various infections and tumors which involves multiple systems, and finally the immunity of these persons will decrease and they will cause death. So what are the ocular manifestations? 75% of patients will have many features, but most common things are retinal microvasculopathy, which is in the retina, usual ocular infections like herpes zoster and herpes simplex. So if a patient comes here with herpes zoster and herpes simplex, we are supposed to do some viral markers to rule out HIV. Opportunistic infections of eye like cytomegalovirus, pneumocystitis, candida, and cryptococcus. Unusual neoplasms, I'll tell you what are the various types of neoplasms, and some neuroophthalmic manifestations and lesions. So what are the things affected? Most commonly is the retina. Neoplasms will be there, opportunistic infections will be there, CNS involvement will be there, and also some ocular infections which are commonly seen in non-HIV patients also, like herpes zoster and herpes simplex. So what are the ocular lesions you see? So ocular lesions, that is adnexal lesions and orbital lesions. So adnexal lesions, so on the surface of the eyelids and on the surface of the eyeball, these are herpes zoster, Kaposi's sarcoma of eyelid or conjunctiva, molluscum contagiosum of eyelid. So adnexal lesions are, these are the adnexal lesions. Now coming to orbital lesions, Burkitt's lymphoma and orbital cellulitis. So sometimes patients with orbital cellulitis, you have to do viral markers. Some people will also present with multiple chalazions. Multiple chalazion, the patient will be recurrent multiple chalazions. We have one patient previously who had multiple chalazions. He is about 42 or 43 years old. He is a male patient. He used to come to a hospital regularly for chalazions, multiple chalazions, both eyelids, 3-4 chalazions he used to have. Somehow we had a doubt and we asked the patient to get the viral markers done, and that patient is HIV positive. Because of lack of immunity, the patient is having multiple chalazions which are recurrent. So coming to anterior segment lesions, dry eyes, conjunctival microvasculopathy, infective keratitis, and anterior uveitis. So this anterior uveitis can be because of the drug used for treatment of HIV, that is rifabutin induced, or it can be a spillover from the CMV retinitis, that is cytomegalovirus, and also maybe due to herpes zoster ophthalmicus. So these anterior uveitis can be any of the below reasons. Okay. So these are the anterior segment lesions. From anterior to posterior I am going. First one is the ocular lesions and the second one is the anterior segment lesions. Now coming to posterior segment lesions. The patient might be having HIV retinopathy or cytomegalovirus retinitis, toxoplasmic retinitis, cytomegalovirus optic neuritis. Sorry, this I have kept in the posterior segment lesions. It should be under neuro-ophthalmic lesions. Pneumocystis carinii choroidopathy, acute retinal necrosis, herpes zoster retinopathy, progressive outer retinal necrosis, and endogenous endophthalmitis. These are all the posterior segment lesions which are caused because of HIV. So neuro-ophthalmic lesions, cranial nerve palsies, papilledema, and optic neuritis. Now coming to anterior segment, molluscum contagiosum, which is caused by pox virus, which is a DNA virus. It consists of multiple umbilicated nodules. So the treatment is excision and curettage. You can see the picture is not that clear. You can see here a lesion is there. This is the molluscum contagium. You can see multiple umbilicated lesions are there here. These are all the umbilicated lesions. Okay, so molluscum contagiosum of the lid. Next, other lesions are hypertrichosis, exaggerated growth of the eyelashes. Cause is usually not known. It can be, the eyelashes can be trimmed, which are causing any irritation, or if they are touching the cornea and causing corneal lesions or irritation to the cornea, we have to pluck them off. You have to pluck them that hair lash, sorry, the eyelash, and you can cause some soothing effect. So you can see here multiple, this how long these eyelashes are. You can see they are very long and multiple there. They are more than the required number. So what is trichomegaly? Usually there will be only 2 lines of eyelashes. But here we can see there are 3 lines of eyelashes. That is called as trichomegaly, which is a part of hypertrichosis. So these are all the features with patients with AIDS. These are not present with everyone, but few people will have few features. Next, coming to Kaposi's sarcoma, it is a vascular neoplasm which is more commonly seen in the anterior segment. It is because of herpes virus subgroup A. Eyelids, you can see purple nodules. In conjunctiva, it can appear as a red mass. Usually we don't see in India. Treatment usually is radiotherapy. So you can see in the conjunctiva, this is Kaposi's sarcoma. You can see this red mass. This is Kaposi's sarcoma, which is very rare in India. Next one is, I told you there are various neoplasms which we can see in HIV patients. Conjunctival squamous cell carcinoma. So this is also called as ocular squamous neoplasia. So there will be interaction between HIV patients with sunlight and human papilloma virus. So there will be a light pink color gelatinous growth. You can, I'm telling you, it will be gelatinous like glistening type. Most common site is temporal bulbar conjunctiva, and this lesion will have feeding blood vessels. So treatment is excision and cryotherapy. You can see here, the conjunctiva will grow onto the cornea like this. You can see it is a glistening type, gelatinous type. Once if you see this patient, you will never forget. You can see here there are feeder vessels are there. You can see these are the large feeder vessels which are present on the lesion. This is also called as ocular surface squamous neoplasia. It is called as OSSN, also called as OSSN. So you can see this is another picture showing, you can see here, this is the lesion. You can see after staining with toluidine blue, you can see there is squamous cell carcinoma also with a deep royal blue staining. You can see here. So there is also actinic keratosis with mixed stain margins and parts of the lesions. So this is a picture of conjunctival squamous neoplasia. So next one is keratoconjunctivitis sicca. So because there is some damage to the lacrimal ducts, there will be in HIV patients, there will be damage to the lacrimal ducts. So there will be severe itching, burning, uncomfortable red eyes will be there. There will be, now what is the treatment for this is you have to reduce the dryness by instilling some artificial teardrops and lubricating eye ointment at the bedtime. So sometimes there will be damage to the glands and lacrimal ducts also, which leads to dry eyes. So now coming to the posterior segment lesions, retinal microvasculopathy, it develops from the vaso-occlusion process, which may be either due to direct toxic effect of the virus on the vascular endothelium or may be due to immune deposits in the peripapillary arterioles. So these lesions are non-specific. So 50% of the patients will have multiple cotton wool spots. 15 to 40% cases will have superficial and deep retinal hemorrhages, and rarely we can see microaneurysms and telangiectasias. So we can see here, these are all the cotton wool spots. Here you can see all these are cotton wool spots. Okay. So usual ocular infections, I told you, there will be some usually the patient with HIV will get affected with herpes zoster ophthalmicus, herpes simplex infections, toxoplasmosis, which affects the choroid and the retina, ocular tuberculosis, syphilis, and fungal corneal ulcers. So coming to herpes zoster ophthalmicus, it is mainly due to reactivation of the latent infection by Varicella zoster in the dorsal root of trigeminal nerve, the Gesserian ganglion. I think you people know this. So it manifests with a maculopapulovesicular rash, which is often preceded by severe pain. Usually involves the upper lid and does not cross the middle line. So it has three phases: acute phase lesions, chronic phase lesions, and relapsing phase lesions. So what is the treatment? We have to advise the patient oral acyclovir 800 mg 5 times per day, or valciclovir, which is 500 milligrams TDS, along with this analgesics, because the patient will be having very severe pain, and also cycloplegics because there is keratitis involving the stroma. To reduce the pain, we have to definitely include cycloplegics in our treatment. Along with that, timolol or any anti-glaucoma drug to reduce secondary glaucoma, because it involves the stroma in the cornea. There will be anterior chamber reaction, or sometimes the patient will have anterior uveitis. So this uveitis, there will be severe pain. Why? Because the cells and flare or the debris, whichever is present in the anterior chamber, it will go and block the trabecular meshwork, raising the intraocular pressure. So all patients should be given timolol or bitoxolol to reduce the secondary glaucoma because of anterior uveitis when the patient is having keratitis. So this is Hutchinson sign. You can see these are the lesions. So this is also because there will be neurotropic keratitis also seen with herpes zoster ophthalmicus. So you can see it is not crossing the midline here, usually involving the forehead and the upper lid, but it may also involve the side of the nose, but usually it will not cross the midline. So what is Hutchinson's sign? You know people, what is Hutchinson's sign? So the patient will have unreactive pupil. Just 1 second. Some So now this is all about herpes zoster. Now coming to herpes simplex infection. So herpes simplex can be primary herpes or secondary or recurrent herpes. So there are two forms. The primary herpes includes skin lesions, conjunctival acute follicular conjunctivitis, we can see in conjunctiva. In cornea, you can see dendritic ulcers or fine punctate or coarse punctate keratitis. You can see this is the superficial punctate keratitis. This is a fluorescent stain. Because of this fluorescent stain, you can see this color. And this is the cornea which you are seeing with the dilated pupil. And these are all superficial punctate keratitis. Small dots, green color dots you are able to see, right? So this is superficial punctate keratitis, which is more common with primary herpes simplex. So recurrent herpes simplex will have active epithelial keratitis, sometimes somal keratitis, tropic keratitis, and herpetic iridocyclitis. I told you the patient will have uveitis, that is iridocyclitis, right? Sorry. The next one is Toxoplasma retinochoroiditis. Uncommon infection in AIDS we see very rarely. Ocular toxoplasmosis in HIV positive patients is different from the immunocompetent patients, like patients without HIV. HIV infected patients will have bilateral and multifocal disease associated with anterior uveitis and vitritis. If it is only toxoplasmosis in immunocompetent persons, the image will be different, and in HIV patients, along with the retina and choroidal involvement, there will be also anterior uvea involvement and also the vitreous. So when testing patients for antibodies of toxoplasmosis, both immunoglobulin G and M levels may be raised, but in patients with HIV, this is negative. So immunoglobulin G and M levels will not be raised in HIV patients. So treatment in immunocompromised patients consists of sulfadiazine and clindamycin along with pyrimethamine and folinic acid. This is called as triple therapy. So you can see toxoplasmosis retinitis. This is called as headlights in the fog. You can see just like headlights in the fog. This is all because of vitritis, which is the vitreous will be having inflammation. Because of that, the media will be hazy. And these are the active lesions, toxoplasmosis chorioretinitis lesions, which will be available, which will be appreciated as headlights in fog. Okay, you can see this is the black color scar which is not active. It is because of previous infection. You can see this white color thing. This is active lesion. So if you have this, the patient will be having active infection. Then if you have a pigmentation along with the black color scar, then it is old lesion. Next one is opportunistic infections of the eye. These are caused by microorganisms which do not affect the normal patients. Because of immunocompression, compromisation, the patients will have opportunistic infections. So there will be decrease in the cellular immunity in patients with HIV. So these patients will have more opportunity for the infections to they are more prone to opportunistic infections. These are CMV retinitis, Candida endophthalmitis, cryptococcal infections, pneumocystis carinii, and choroiditis. Now coming to CMV retinitis, it is the most common intraocular opportunistic infection in patients with AIDS. So pathogenesis, reactivation from the extraocular sites leading to seedling in other sites such as retina. So cytomegalovirus will cause retinitis. Patients mainly complain of minor visual symptoms like floaters, flashes of light, or any mild blurring of vision will be the most common presentation, or sometimes the patient will be completely asymptomatic. So all patients with HIV positive should be searched for any CMV retinitis. So we have to dilate the fundus and definitely see the fundus. It presents with wide range of clinical appearances from cotton wool spots to full thickness retinal necrosis and vasculitis. So mild to very severe forms. It can progress in a brush fire pattern from the active edge to the active lesion. You can see Sometimes it may even lead to, see, you can see this is brush fire pattern. You can see like this, right? So you can see there is retinal detachment in this patient. Here the retina is intact, but you can see the retinal detachment. You can here also see the brush fire appearance, right? So the treatment is ganciclovir, cidovir along with heart. Okay. So the treatment can be administered both orally, intravenously and intravitreally depending upon the severity of the disease. Next one is Candida endophthalmitis by Candida albicans, which is very rare with a history of drug abuse or indwelling central illness. The patients will be more prone to Candida. In initial stages, floaters are the main symptoms, and it progresses. There will be whitish ship of balls and vitreous strands develop. You can see here, this is a ball, right? White, sorry. You can see these are the whitish fluff balls which are typical of Candida endophthalmitis. And the drug of treatment is amphotericin B and fluconazole. Now coming to cryptococcal infections, mainly occurs by inhalation of the airborne spores. Organism initially remain in the lungs and they spread to other parts hematogenously, that is endogenous spread. Intraocular infection may occur via direct extension from CNS or through the blood. So most of the infections have been seen in association with the cryptococcal septicemia with meningeal infection. You can see how the retina, how the fundus is. You can see hemorrhages here. You can see inflammation of the optic disc, right? So now coming to pneumocystis carni, it causes choroiditis, very common in earlier years of HIV pandemic, but use of systemic antimicrobials like trimethoprim, sulfamethoxazole eradicated these ocular manifestations. So you can see there are deep orange lesions. Usually they don't affect any visual acuity. So this is another picture of Kaposi sarcoma. You can see here this reddish lesion, right? So next one is Burkitt's lymphoma of the orbit, seen very rarely. Other neuro, so I told you some neuro-ophthalmic lesions also will be there. So these are thought to be due to cytomegalovirus or other infections of the brain. So there will be cranial nerve palsies which can be isolated or multiple nerve palsies involving which results in paralysis of the eyelids and extraocular muscles, loss of sensory supply to the eye, and optic nerve involvement causing loss of vision. So patients with HIV, they might have loss of vision because of retinitis or optic nerve involvement or because of toxoplasmosis or any CMV retinitis involving the central macula. So these are the main causes, and even sometimes anterior uveitis, the patient will have decreased vision. So this is another picture of molluscum contagiosum. This is rifabutin induced anterior uveitis. You can see here there is an hypopion. So rifabutin, I told you anterior uveitis can be because of rifabutin. So that's it. So any doubts? Are you people are listening or not? I don't know. I'll just stop recording first.